Thank you so much. We've heard from the Director General of Africa CDC, who has given us a blow-by-blow account of how Africa CDC has been able to move right from inception to this very moment, where we now have a strategy to support member states in the areas of mental health prevention and control. We started by talking about the problems with mental health on the continent, and how Africa CDC has set up a new division, and the division starts with non-communicable diseases, injuries, and mental health, and how the strategy that was recently validated in Addis Ababa, with over 150 participants from member states and 7 ministers of health, and now way forward on this day of that we're celebrating the World Mental Health Day, and using this event as a climax of what we've been doing in Africa CDC to celebrate this year's World Mental Health Day. May I add here that Dr. Ahmed has been the pillar of support for the non-communicable diseases, injuries, and mental health work that Africa CDC is doing. He's a very strong supporter of NCDs, and he knows NCDs is an area that Africa is going to be to really need to prepare for, and we're very grateful for all the support you've been giving to the division to get us to the position where we can really support non-communicable diseases, injuries, and mental health prevention and control. We say thank you, a very big thank you to Dr. Ahmed, and I will also use this opportunity to introduce my co-moderator, Dr. Adelad, who is a technical officer in the Division of Disease Control and Prevention. Myself, I'm Mohammed Abdulaziz, the head of division of that division that Dr. Ahmed just made reference to, as the division that is working very closely in Africa CDC for the prevention and control of non-communicable diseases, injuries, and mental health. So we, like I said, we've listened to the keynote speech by the no other person than the highest level in Africa CDC. Now we will listen to a presentation by an eminent person in the specialist, mental health specialist on the continent, Dr. Naim, who is going to be talking to us on mental health landscape on the continent. Over to you, Dr. Naim.
Very good afternoon from Lusaka, Zambia colleagues. Dr. Abdulaziz, thank you so much. And a brilliant keynote speech from Dr. Ahmed, very astounding figures that we all need to be aware of. This is something that as specialists we are going to speak to in more detail. Dr. Adilad, I'll request you to share my slides, please.
Dr. Alad, can we make Dr. Naim Dalal a co-host so that he can show his slides? Very good.
All right, so welcome to everyone to the World Mental Health Day Landscape of Mental Health in Africa short presentation. My name is Dr. Naim Dalal, and I'm coming to you from Lusaka, Zambia, and also privileged and honored to be part of the high-level advisor for the NCDs, injuries, and mental health strategy that Dr. Ahmed just spoke about that Africa CDC has launched. Next slide, please. So what is the landscape of mental health in Africa? Where are we as a continent? What do we know about mental health, and what are we doing about it as a continent? Next slide. So by the end of this short presentation, you will be able to understand the landscape of mental health on the African continent. And we're going to understand this by understanding the current mental health service delivery platforms that we have in the member states of the Africa continent. We're also going to specifically focus on youth mental health needs. As we are aware, and from Dr. Ahmed's keynote speech, ours is a population on African continent, which is quite growing steadily with a projection of 2 billion in the near future. And also the need for us to understand why this is a very key population that needs to be focused on. And of course, when we talk about health, We also talk about the social and cultural aspects of health. And this is where I'm going to focus on the cultural and religious holistic approach to mental health, which is often not seen from the Eurocentric and American focus of mental health. So these are the things that we're going to look at in the next few slides. Next slide, please. So talking about the mental disorders, and globally, we know that 14% of all health disorders have to do with mental and neurological disorders. So that's out of 100%, 14% is mental health as well as neurological conditions. Now, why are we focusing on mental health in particular? Out of that 14%, 75% of the global burden of mental health is in low and middle income countries. And this includes the African continent. And again, the African continent actually has the youngest population all over the world, with 60% of Africa's population below the age of 25 years. Now, again, why is this important for us to know? Because a leading cause of death amongst young people below the ages of 29 years is by suicide, by the act of self-harm. And also, it is also very important for us to know that the current mental health systems that are applicable all over the world are impractical, ineffective, and require a lot of resources. They are resource intensive to succeed in lower resource regions. And this is why the landscape for mental health in Africa is different. Next slide, please. Looking at this slide, it looks at a pyramid structure of the current mental health systems globally. If you look at the frequency of need on the left side of the slide, it goes from high to low. And on the right side, it looks at the costs from the high to low. When we look at the base of the pyramid, we are talking about self-care, where are individuals aware of their own mental health and self-care. And then we talk about informal community care. On the African continent, we have friends, family, cultural, religious, as well as community spaces where we often get support from. And this makes up the base of mental health care. Then we talk about primary care mental health services. Looking at the African continent, unfortunately, primary health care has not yet embedded and integrated mental health services in primary care. And then a step further, as we go on to refer, we talk about psychiatric services in general hospitals, as well as community mental health services. Again, this is further up on the pyramid, and we need to understand that the higher we go, the higher the cost implications are. And finally, at the top, at the apex of the pyramid, we have long stay facilities and specialist psychiatric services. Already from the keynote talk from Dr. Ahmed, we already know that there is a 1.4 mental health worker per 100,000 people compared to the global 9 per 100,000. Now, when we look at this pyramid, unfortunately, when we talk about formal services on the African continent, we have quite a long way to go. However, informal services are present in the structures of religious care, cultural care, as well as just community support. Next slide, please. Where is the gap when we look at this pyramid? There is a gap when it comes to specialist mental health care services. And this is why the Africa CDC mental health NCDs and injury strategies speaks about task shifting and healthcare worker enforcement when it comes to mental health services. However, on the African context, we do have a generally good structure for informal community care. This is something that has been improving over the past few years. And with COVID-19, we have seen that we are each other's keepers on the continent. However, there is a huge gap as we talk about the African landscape of mental health. When we talk about primary healthcare services, when we talk about specialist psychiatric services or specialist mental health care services, and further specialist tertiary mental health care services or hospitals. Next slide, please. So this is where I now bring you to a food for thought. We now know that there is a global burden of mental health care services. And further, when we come and talk about the African continent, yes, there is a burden as well. Now, we want to change that thought process by saying, imagine a future where you see a healthcare provider, not because you are sick, but because you want to avoid the possibility of falling sick. And this is what we talk about this year's theme, mental health for all. Click on. Current reality is that health systems promote improving the quality of care provided, improving patient outcomes, and reducing the cost of care. This is how the current landscape of healthcare systems, including mental health care services, are. And we need to change this to preventive, promotive, as well as curative care that is cost-effective and inculcates the actual resource limitations that we have on the continent. Next slide, please. So we bring in the concept of the biopsychosocial model of disease. According to the World Health Organization, we know that health is a complete state of physical, mental, and social health. It's not just the absence of disease. In health, we also have mental health, which is part of it. And if we want to look at healthcare services in mental health, we need to look at the social factors, the biological factors, as well as the psychological factors. Next slide, please. So what do we mean by the biopsychosocial model? The biopsychosocial model of health and illness is actually a framework which looks at all the different risk factors that can predispose any individual from having a mental ill health. And as highlighted from the keynote from Dr. Ahmed, all the various socioeconomic stresses that the African continent is currently facing are actually part and parcel of mental health care for all and services. Biologically, we talk about the inheritance, we talk about the gender, we talk about the disabilities and everything that an individual inherits in families. Psychologically, we talk about the learning behaviors which are very unique to each continent and in specific the African culture. The attitudes, the beliefs, all of these are very specific to the African continent. Then we talk about social factors. Social factors talk about the socioeconomic status of communities, the education background, traditions, religious norms, all of this actually interplay in enabling an individual from having good mental health versus ending up with a mental health illness. Next slide, please. We can't speak without talking about the COVID-19 pandemic. The one thing that the COVID-19 pandemic has taught us is that the health systems are one and united. When we looked at the COVID-19 pandemic, children, young people, and families were affected because there were school closures. And this has led young people to be exposed to substance use, such as alcohol, such as drugs. There have been an increase in domestic violence. There has been a change and disruption of social networks. We talk about the older communities. There has been a generational divide as there has been more isolation and end-of-life care and bereavement. People with existing health issues such as non-communicable diseases, because of COVID-19, these diseases were not being treated because there was disruption in care, including mental health. We talk about mental health care workers. Because of the fear of contamination and other stresses and stigma that healthcare workers went through, they themselves have gone through certain injuries when it comes to mental health. Next slide, please. Again, we keep talking about the vulnerable communities. On the African continent, prisoners, the homeless, as well as sex workers, these are socially excluded groups that also require a tailored response when we talk about health services. Low socioeconomic class, where majority of the African formal and informal health workforce lies, they actually face job and financial insecurity because of the pandemic. And this again has predisposed risk factors to mental illness. There's also the social cohesion. And this is something that Dr. Ahmed also mentioned in his keynote, to say there's a lot of rural to urban migration taking place. Again, this in itself is a risk factor to mental ill health. And of course, disabilities that often do not get the care that they need. Next slide, please. So, COVID-19 and its consequences, we cannot speak about mental health right now on this World Mental Health Day without understanding the last 2 years and its effects. Right now, on the African continent, homes, majority of the countries have seen homes turned into alcohol drinking places. There has been an increase in surge of reporting at sporadic member states where they have seen that there is an increase in substance misuse. There has been an increase in child abuse in homes and in communities. There has been an increase in job losses. There has also been an increase in domestic abuse. And also there has been across the African continent in media, there has been an increase in reporting of self-harm and suicide. Next slide, please. What does this mean about the pandemic? One thing that the keynote has addressed from Dr. Ahmed is that this is COVID-19 and we are seeing a surge. We will only know the actual impact post-pandemic, which we are going to start reporting as we go on. With the pandemic, we saw a surge of the first wave. We saw a lot of people pass away due to COVID. In the second wave, we also saw that there was a restriction of existing health systems. And now we are actually seeing a surge of psychiatric as well as psychosocial injury that we are actually just seeing with time that goes past. Next slide, please. We now switch our focus onto mitigating stigma. When we talk about mental health, and particularly about mental illness on the African continent, we cannot speak about it without talking about stigma. There exists a high stigma when it comes to mental illness, as mental illness is considered to be spiritual in nature, religious in nature, or a sort of bewitchment or curse. This is not something that we should do away from. As mental health specialists, we embed and we respect this belief, as this is part and parcel of our whole identity as Africans. We need to understand that there is a need in achieving the right balance between health information and mitigation of negative socioeconomic effects that is required. Communication and information dissemination is required for mitigation of stigma. What do we mean by that? We need to communicate in our communities about the safety needs, the physiological needs that come because of the socioeconomic stresses that we are facing currently in many countries in the continent. But at the same time, we need to understand that we need to include strategies to help individuals stay informed by specialists such as mental health experts to help mitigate and manage the effect of understanding the various burdens and risks that I alluded to earlier. We also need to embed culture in our understanding of mental illness. Next slide, please. What are Africa-centric needs when we talk about mental health care for all on the African continent? At the very bottom, you see the roots. The roots are actually the young population. That is 60% of Africa's population is below the age of 25 years. We need to start embedding all these specific identities for our communities. The need for culture-specific coping strategies. As a continent, we are very rich when it comes to our culture and our spirit of belonging. We do not do away from that. We actually embody that within our treatment support services. We have to talk about local languages of awareness, acceptance, and health promotion when it comes to mental illness, so that we move away from the concept of being bewitched or the stigma that this person is crazy or this person is mad. There is more awareness and understanding about mental illness, which we need to promote in our local language. Things like anxiety, depression, schizophrenia, these are terms that are not understood in our population, and we need to use and embody local language. Also talking about brain health, bongo. When we talk about the brain, we often think that it is very detailed. We need to talk about it away from stigma and promote it as a health organ. Further to that, talking about the mental health gap, which arguably is all over the world, but specific to Africa, we need to increase in terms of our task shifting in our resource limited settings. We need to have mental health care professionals at all levels of the pyramid. We shouldn't just wait at the apex of the pyramid, but mental health care task shifting should take place from community level to primary healthcare level. We also need to talk about research and implementation, because the current research and evidence that we often see in the field of mental health is Western-centric and American-centric, North American-centric. We need to focus on our own cultural, intensive research awareness when it comes to mental health. And of course, mental health and psychosocial support in emergency response. And this is something that the Africa CDC started doing with COVID-19. We need to continue doing this with existing emergency response. Like currently we are seeing a surge of Ebola in East Africa, and we need to make sure there is specific psychosocial intervention right in the emergency response. This is mental health for all in the Africa-centric structure. Next slide, please. Now, colleagues, in Africa, we cannot talk about mental health in particular without focusing on the young population. I keep coming back to this because 60% of Africa's population is below the age of 25 years. And with the projected increase in the population in the next few years, we are going to see a younger population mushrooming on the African continent. Also, according to global statistics, the 10 youngest countries in the world, according to age, are on the African continent. So we are a very youthful population. Having that said, I share with you this slide on the burden of disease and disorders from Origin Australia as well as Melbourne University. What did they do? They put together all the various disorders that are there and diseases. And when you see that life trajectory of all diseases, you will notice in yellow, we have mental disorders. And when we talk about the yellow, we also look at the age. When you look at the age ranges, there is a peak from the ages of 15 years to 25 years of mental health disorders. Did you know that up to 25% of disorders actually start as early as the age of 14 to 15 years? And by the time an individual is 25 years, you can diagnose up to 75% of mental health disorders. And this is why you see this peak. When we talk about disease burdens, including on the African continent, there is a peak of mental health disorders between the ages of 15 to 25. And this is where we need to focus our assessment and our treatment. Disappear as individuals reach the ages of 50 to 60 to 70. No, this means that there are a lot of people that have premature mortalities and die early on because of lack of treatment and support. So these are discussions that we need to have specific to the African landscape of mental health. With that said, colleagues, I end my presentation, and it has been a privilege and honor to share this day with you. Thank you.
Thank you so much, Dr. Naim Dalal, for this excellent presentation that really set the stage for the discussion. And after the powerful message and call for action from our director and this excellent presentation, that really zero in to the Africa-centric needs, we'll now hear from Dr. Carol Lebo, who is the presidential advisor in the President's office in Sierra Leone, who will now, in the same vein of the theme of this commemoration, talk about the advocacy to prioritize mental health in member states. Dr. Carol, the floor is yours.
Good morning, everyone. I stand on existing protocols and thank you for the invitation to join this esteemed panel. In Africa, we must ambitiously embark on a journey as we reimagine mental health. First slide, please. First slide, Dr. Adelaide.
Yeah, sorry, it's coming.
Okay, thank you.
apologize. It's on now, Dr. Carol. You can go ahead.
Hi, thank you, Dr. Adelard. So within the theme of make mental health a global priority for all, I'm here to outline what it looks like for Africa CDC and all Africa member states. Next slide, please. Before COVID-19, as Dr. Ahmed said, 1 in 8 people globally were living with a mental health disorder. Throughout Africa, there are huge treatment gaps, the lack of skills, lack of funding, especially in low to middle income countries. Here in Sierra Leone, there's less than 1 psychiatrist for every 1.5 million people, and less than 1/10 of a US dollar per capita is spent on mental health. COVID-19 is a global crisis, and as we look to COVID recovery, we know that the pandemic has spread fear, uncertainty, and stigma. Lockdowns, isolation, has increased anxiety, socioeconomic pressure, depression, and other ills that have affected us globally. Mental health needs to be increased. The supply of services has been disrupted and decreased, and accessibility and availability to care is limited. So within that, I say that we envision Africa where mental health is prioritized for each and every individual, family, group, community, and district. Starting from maternal and child mental health, prenatal, antenatal, perinatal, we will support the mental health and well-being across all life stages with a focus on prevention and early intervention. In Africa, where we are integrating mental health services into PHUs, secondary and tertiary hospitals, and prioritizing skills to improve mental health outcome. In Africa, where everyone from health workers to CHWs to MCHAs to social workers to school counselors, you and I can provide and support the mental health and psychosocial support services to improve mental health outcomes. In Africa, where we build capacity with and for community organizations, civil societies, NGOs, INGOs on stigma reduction. In Africa, where we support individuals across the mental health spectrum. In Africa, where we expand inpatient and outpatient services and holistically teach skills to set the stage for recovery, management of condition, and teach cognitive skills and emotional regulation to decrease chances of relapse and prioritize mental health outcomes. In Africa, where we provide culturally and linguistically appropriate services and interventions for children, adolescents, and youth who may be genetically predisposed to mental health disorders, trauma-related disorders, neurological disorders, fetal alcohol syndrome, addictive genes, and exposed to adverse childhood experiences. In Africa, where staff mental health and well-being is prioritized and our offices are psychologically safe. Finally, in Africa, where mental health and well-being of vulnerable population, women and girls, survivors of SGBV, persons living with disabilities, inclusive of the visually impaired, the hearing impaired, HIV, cancer, TB, malaria are prioritized. I thank you for the opportunity. Reimagine Africa with mental health at the forefront.
Yes, thank you so much, Dr. Carol, for highlighting again the challenges with regard to mental health on the continent, and strongly advocate for prioritizing mental health at all levels. I think we have now here on the challenges. It's now time really to hear from a speaker that's have been working with Africa CDC on developing the strategy on mental health and also guiding the implementation. Here I'm calling Professor Latif Sheikh, who will now talk on how can African country benefit from the Africa CDC for mental health promotion in the short, medium, and long term. Professor Latif Sheikh, the floor is yours.
Thank you very much, Dr. Adelard. I want to stand on the existing protocol, but I would like to specifically recognize the presence of the Director of Africa CDC, and also Her Excellency Dr. Carol and other excellencies that are actually listening to us. I also want to appreciate Africa CDC for the privilege to come and present here. I've been enjoying my work with Africa CDC in regards to mental health, and I'm saying that a lot is being done and a lot still has to be done. Would you like to share my slide, or you want me to share it from here?
I'm uploading it, Prof.
Okay, so go on, keep uploading. I'm delighted that I'm going to be talking about how Africa CDC strategy, how it will benefit member states in the short term, medium term, and long term. The Director of Africa CDC has said so much. In fact, if all our leaders will be speaking like the Director of Africa CDC, I'm sure the landscape for mental health in Africa will change very, very rapidly. And I also appreciate the practical presentation of the landscape of mental health in Africa by my colleague, Dr. Dalal. We've been working together. It's a real mind-opening presentation that will guide us seriously on this matter. We appreciate the experience of Dr. Carol. We were in Tanzania together, and what she's doing with regards to mental health is very encouraging and something that we need to applaud. Your Excellency, thank you very much for the great work that you are doing regarding mental health in Africa. We appreciate you a lot. Thank you.
Thank you, sir.
You're most welcome, ma'am. So while you are sorting that, maybe I will start with the background. We've heard a lot about the background of the mental health situation in Africa, which is quite pathetic. Looking at it from all ramifications, we have so much to do. And if we listen carefully to what Dr. Dalal had said, we need to follow the principles, the ingenuity of Africa CDC, that we need to dig inward and dig indigenous and find our own way of solving our problems. Because looking at the Western orientation, it will be copying something that is quite expensive and will be very difficult for us to implement. So I really applaud Africa CDC coming up with this strategic plan that is making Africans to use what they have to get what they need. Until we do that, we will be copying what we cannot do. And like you saw in the graph, one of the graphs that Dr. Dalach presented, it would be very expensive, and we will not be able to do that. Our circumstances are not the same. Our situations are not the same. The way our perspectives of our mental health in Africa is not the same as the Western countries. And we're going to prove that. We'll show you. Thank you. Thank you very much, Dr. Adelaide. So we can just go straight to the next slide. Some of the things I may be saying may appear that I'm repeating, but I'm just trying to place the emphasis where it should be. Mental health is one of the most neglected areas of health in the world, not only Africa, but it's even worse in Africa. As we can see, we've been listening. And despite the impact of mental health conditions on individuals, families, and society, there has been very little investment in mental health, particularly when we talk about community-based services. Our type of community settlement, our type of community networking in Africa is completely different from what you find in the Western countries. So our approach to community-based services in Africa cannot be a mirror of the kind of community-based services that you find in Europe or in North America or Japan. So we need to be very conscious of this. Public expenditure on mental health are very meager in this part of the world. We spend between 1 to 2% of our budget on mental health. Of our health budget, actually, not total budget. I want us to understand this. Our health budget, not even total budget. And more than 80% of these funds go to standalone mental hospitals. So it doesn't really, sediment to the community level. International development assistance for mental health is estimated to be less than 1% of all development assistance. And I want to bring our attention to this, that we get funding for various types of interventions, HIV, tuberculosis, etc. However, we know that mental health is embedded within HIV, within tuberculosis, within all other conditions. And when international agencies, when donors come to give us assistance on HIV and tuberculosis, before now, they don't accommodate mental health. And we know that mental health is a huge part of these other conditions. So all these need to change. Notwithstanding the high levels of mental health disability, more than 85% of people with severe mental illness in low and medium income countries do not receive the care they require. And we refer to this as the mental health gap, mental health treatment gap, the gap between what we have and what we need.